Hello guys, good day everyone. Today in our Mission 200 place, we are going to discuss the Pathology Rapid Revision Program. In this, I'm going to include the most important topics of general pathology only, and coming to the hematology and the systemic pathology will be included in the medicine, and we are going to revise that. So let's start with the first and basics importance. First, normal cell. So whenever the normal cell will have the stress, okay, when the stress will trigger, it is going to start injuring by itself. How? So sometimes it can be reversible injury and sometimes it can be irreversible injury. So when we see under the microscopy, how can we see what is the injury of that cell? Is it reversible or irreversible? So what are the changes that we are going to see? In the reversible injury, there will be membrane blebbing. So that means cell swelling kind of, and mitochondrial swelling and cellular swelling. Why this change is coming? So when there is a hydropic changes, okay, when there is a hydropic changes or when there is a fatty changes, these kind of changes will be seen in the reversible injury. And next, it is already, let's say it is already extended to the irreversible injury, then there will be a rupture of lysosomes and membrane damage and mitochondrial permeability. And in the classically, what we say, amorphous densities. Okay, on the electronic microscopy, when you see this amorphous densities and calcification, so this is the classical sign of the hallmark of the irreversible injury. Along with that, pycnosis, karyorehasis, and karyolysis. These kind of also seen in the irreversible injury. Then, what is the most common cause for this injury? The most common cause is the hypoxia, decreased oxygen to the cell. And which is the very fast to get this hypoxia? The neurons. Neurons are more prone and sensitive to get damaged by the hypoxia, right? This is the changes of the reversible and the irreversible changes. Next, moving on to the cells and their properties. So first, what is the property? First thing that you have to discuss, hypertrophy. What does mean by the hypertrophy, guys? It is increasing in the size of the cell. Okay, this is increasing in the size of the cell. Where you are going to see example, you are going to see this in the exercise. When you do the more exercise, your muscle going to bulk, and commonly in the left ventricle hypertrophy in the hypertension patients, right? It need to pump more and more pump will lead to the hypertrophy of the left ventricle muscle. And also breast lactating mothers, okay, breast lactation mothers, and along with that also uterus in the pregnancy, uterus in the pregnancy. So these are commonly seen with the hypertrophy. Next, coming to the hyperplasia. Hyperplasia is different. It is increasing in the cell number. Okay, it is increasing in the cell number, and also along with that there will be a increasing in the size. These both are seen in the hyperplasia. And what are the example? One of the example, benign prostatic hyperplasia, endometrial hyperplasia, like pathological conditions. Next, breast in the pregnancy. Okay, breast in the pregnancy and also breast in the puberty. These are going to increasing in the size and also increasing in the number. Next, dysplasia commonly seen in the lesions, right? Neoplasia lesions. What is meant by the dysplasia, guys? It is not about the number. It is disorganized. Okay, it is disorganized and rapidly producing, seen in the neoplasia. Next, metaplasia. Metaplasia is like changing. Okay, one layer of cell to another layer. Okay, one layer of cell to another layer. So what are the example? The best example is the Barrett's esophagus, right? Barrett's esophagus. And what is the other one? Chronic smokers. In the lung epithelium will also going to change in this one, right? Chronic smoker. And Barrett's esophagus is high risk for producing the adenocarcinoma. In the Barrett's esophagus, what is the epithelium that is going to change, guys? So basically, it is a columnar, it is squamous epithelium, right? It is going to change into the pseudo stratified. It is going to change into the pseudo stratified columnar epithelium. Okay, this is the one that is going to seen in the Barrett's esophagus. And coming to the atrophy, it is going to decrease in the size and at the same time it is going to decrease in the cell number. So what are the other commonly? It is due to aging normally, or it is due to Alzheimer like conditions, like brain is going to shrink by its own, or it can be due to nutritional causes. Okay, cachexia, all these causes can be also seen in the nutritional wise. Next, we have the two types of the injury, and after this injury, irreversible injury, what happens? Either it will go into the necrosis or it will go into the apoptosis, right? So let's see the difference between the apoptosis and the necrosis. Here the picture, here you can see this is the apoptosis and this is the necrosis. On the electron microscopy, if you see, this will look like this: membrane blebbing, apoptotic bodies, and these cell membrane will be damaged. Right? Next, see the differences mainly. So what is mean by the necrosis and what is mean by the apoptosis? Okay. So apoptosis is mainly about the programmed cell death. Okay. It is programmed cell death. Whereas necrosis is a enzymatic death. Enzymatic death. And most of the times our apoptosis is physiological and at the same time it can be pathological. But necrosis is always pathological. Necrosis is always pathological. And here you are going to see the changes like there is no inflammation. After the apoptosis, you don't see the inflammation. But in the necrosis, you are going to see the inflammation is present. And for the markers, you have the CD95 as a marker and no marker, no specific markers for the necrosis. Okay. And this is the major changes. And this one, here you can see this smearing. When you do the smearing, you are going to see the step ladder pattern. Okay. This step ladder pattern you will be seeing in the apoptosis, where just smearing will be seen in the patients of necrosis, right? This is only the main difference that you have to remember. Next, coming to the necrosis, types of the necrosis. Here you can see what is this one. This is the coagulative necrosis and most common among all the necrosis. What happens in the coagulative necrosis? It is denaturation of proteins from the organs. It is denaturation of proteins commonly seen in the MI patients, right? In the MI post, if there is a ischemia, this will be caused as the most common, and all organs will be associated with the coagulative necrosis except the brain. Okay, except brain. And also dry gangrene is also seen in the coagulative necrosis. Okay, next, liquefatic. Liquefatic is associated with the brain. Okay, liquefatic is associated with the brain, and also fungal infections and abscesses. Okay, abscesses. Along with that, also wet gangrene. Why liquefatic is associated? Because this is most commonly seen with the enzymatic damage. Okay, it is associated with the enzymatic damage. Next, fat necrosis is commonly seen with the most of the fatty tissues like breast is involved, and also pancreas is involved, and omentum. Okay, and omentum. These are the organs associated with the fat necrosis. Next, gangrene necrosis. Gangrene necrosis are wet gangrene and the dry gangrene, right? Wet gangrene is mostly infection. Dry gangrene is due to decreased blood supply. Caseous necrosis is also known as a cheesy necrosis. Okay, cheesy necrosis. And there will be associated with the tuberculosis and also histoplasmosis histoplasmosis. And fibrinoid, this fibrin, this pink structure will be deposited. For example, rheumatic heart disease and also polyarthritis nodosa. These are the commonly for the fibrinoid necrosis. Next, coming to the dystrophic calcification and the, okay, before that, we also see the apoptosis, some of the important points of the apoptosis. Okay, when I say apoptosis, it is two pathways. One is the intrinsic pathway and other one is the extrinsic pathway. And ultimately, all these has to enter for the execution to killing. Okay, execution to killing. In this, you don't have to know the entire pathway now. But what else we have to understand here? What are the important that are included? For the intrinsic pathway, the involved caspases here is the 9. Okay. For the extrinsic, E for extrinsic and E for 8 and also 10th one. Next, execution to kill, that is going to be the 3, 6, 7. These are the most important parts. Next, what is the other thing that you have to remember? Apoptosis markers are CD95 and also anaxin, and after that phosphocylin. Okay, phosphatidylserine is also play the major role in the apoptosis marking, right? These are the things that you have to remember. Next, also some of the other things are present like necroptosis, pyroptosis, the necroptosis. Necroptosis, the name itself you can understand, this is a misnomer. Either it is a necrosis or the apoptosis. What is this one? This is programmed necrosis. Okay, this is programmed necrosis seen in viral infections. Okay, seen in the viral infections, and along with that neurodegenerative diseases and acute pancreatitis. Next one, pyroptosis. Pyroptosis is seen in the fever with the help of the pyrogen IL-1. Next, you have also ferroptosis, which will be increased ferrous or the ferric level in the body. Ferrous are the ferric levels in the body seen in the stroke patients. Okay, seen in the stroke patient. These are the important points, apoptosis and other types of you have to remember. Next, moving on to the dystrophic and the metastatic calcification. D for dystrophic and another D for disease. Okay, all the deceased or the dead will be presented with the dystrophic classification. And next, calcium. When you check the calcium, it is going to be the normal in this patient. Next, metastatic is present in the living tissues. Metastatic is present in the living tissues. But after checking the serum calcium levels, either it could be increased or it could be decreased. This is what's seen in the metastatic calcification. Next, what are the example? Rheumatic disease, right? Rheumatic disease and also atherosclerosis, okay, TB and somoma bodies. Somoma bodies. Next one, in the living tissues, what are the examples? When the calcium is increased, remember with the calcium homeostasis, what is the major role that play? Parathyroid, right? So, parathyroid related diseases that will increase the calcium. Next, vitamin D will also play, and vitamin D related diseases and multiple myeloma, kidney related diseases. Whichever increasing the calcium level, that is going to cause this one. And sarcoidosis also presented with the hypercalcemia, right? These are the examples, and what is the difference between the dystrophic and the metastatic calcification, right? Next, here we will see some of the important stains that you have to see. The most common stain is used in the histopathology, that will be hematoxylin with the eosin, right? This we are going to use. And for the lipids, we are going to use the Sudan black and oil red, okay, color. Black and red, that is going to be used for the lipids. And next, glycogen. For this, we are going to use the periodic acidic skiff that we are going to use. And next, copper. For the copper, rhodamine. And for iron, Persian blue. For the iron, Persian blue. And for the calcium, Vancosa. And for the melanin, Masun Fontona. Okay, Masun Pantona. Tan, here itself, the tan Pantona. Collagen, Masun trichome. Okay, and amyloids with the help of Congo red, right? And mast cells, okay, thylidine. These are the important stains that you have to remember we are going to use. And another miscellaneous and important topic, vacunator's tubes. Okay, for this, let's see the red color. Red color does not contains any anticoagulant we are going to use for the serological examination for the biochemistry. Okay, for example, your serum electrolytes such as other one like liver and also kidney, all that we are going to carry in the red tube. And next, these gray color tube which will be containing of the sodium fluoride, important for the glucose because it is going to inhibit the anolase. Okay, it is going to inhibit the anolase. Next, another one, this lavender color used with the EDTA, which is only useful for the complete hemogram like CBP or the erythrocyte sedimentation rate. Next, sky blue color, which will be contains of the 3.2% of the sodium citrate used for the coagulation studies such as prothrombin on the anti-prothrombin time. Next, green color tube, which will be containing the heparin used for the bone marrow studies. Yellow one, which will be containing the citrate used for the blood culture and also blood bank purposes. And light pink color is contains the K2 EDTA used for the blood bank test ABPO group. And but nowadays this is not usually using. In the yellow color tube only we are going to use for the blood bank also. These vacunators and types is also very important for us to understand. Next, moving on to the next topic, that is the acute and the chronic inflammation. Let's see. First one, we have the acute inflammation. What does mean by the acute inflammation? It is very short and very fast inflammation associated with the IgM. And in this IgM, what is the major role that is going to play by the neutrophils, right? This is the major one that is going to play. Next, see the events. It is going to contains the vascular events followed by the next killing and the phagocytosis. In the vascular events, let's see, this is the normal axial flow of the percentage. So when there is a stress, when there is a triggering factor, stress, this will cause the margination and the pavementing. Okay, margination and the pavementing. In the vascular events, what is the first thing that is going to happen? Earliest, that is going to be the vasoconstriction. This is the earliest point. Okay, this is the earliest point. And after this, it is going to cause the vascular permeability. It is going to cause the vascular permeability. This is the hallmark of, this is known as a hallmark of acute inflammation, right? Followed by the vascular permeability, it is going to cause the margination and pavementing. Okay, where you are going to see the stasis of blood. Okay, stasis of blood you are going to see in this margination, followed by rolling and adhesion. Okay, next, immigration and diapedesis, chemotaxis and killing, right? Chemotaxis and phagocytosis. Let's see one by one what is happening in this cellular events. Once upon a time, there is a question is also asked in this picture. Order wise, you have to order this in the ascending wise. That question is also asked in the examination. Let's see. So first, here the normal flow where there is an increased blood circulation here. Again, there will be a vasoconstriction, vascular permeability. Once it is going into the margination, it is going to cause the stasis, and these stasis will cause at a time the pooling of the blood is happened. Next, there will be a rolling over. Here you can see this is the type of the rolling over. Once rolling over is completed, it is going to attach adhesion to the endothelial cells. Then immigration and diabetes coming outside of the endothelial cell within the gap. Right? This is what happening. After diabetes, there will be a chemoattractants, chemosis, and next phagocytosis will be. And let's see what are the properties that are going to play the major role. So here we have seen that the vasoconstriction, vascular permeability is majorly done by the histamine and also serotonin and platelet aggravating factor. All these are going to play the role. Next, what about the rolling? In the rolling, we have the two type in the margination and the pavement. After that, what are the other things that are going to play role? in the rolling. So we have the rolling, there will be a selective things. Okay, rolling is going to have the property known as selectins. Okay, these selectins is going to play the major role. What are those? E selectin and P selectin and L selectin. Okay, E for endothelial. Okay, E for endothelial, which will be containing of the Cialis X factor. Okay, Cialis Lewis X factor. Next, please P selecting factor. This is the platelets. And next L for leukocyte factor, which will be associated with the glucam 1 and CD34. Okay, glucam 1 and the CD34. Rolling will be going to help in that particularly these neutrophils going to roll over onto the endothelium. Next, adhesion, attachment to the endothelial cell. What is going to help? The adhesion we are going to help by the beta integrin. Okay, beta integrin with the help of VCAM1. Beta integrin with the help of BCAM1. Then migration and diapedesis. Diapedesis between the two cells, right? Between the two cells of the endothelium, we have to come out that neutrophil. What is going to be the help for the diapedesis? PE. So remember this as a PE-CAM. Okay, PE-CAM. This is going to help in the neutrophil to come out of that vessel. So, okay, these are the important points that you have to remember. Next, chemoattractants. Okay, these chemotaxins like CC or the CEC, all these are going to play role that going to attract towards to the bacterial cell wall. For example, let's say these chemoattractants are two types. Okay, these chemoattractants are two types. What are those? One is exogenous and other one is the endogenous. In the exogenous, we have the bacterial cell wall. That cell wall itself contains the many types that is going to attract this. And endogenously, other one are the leukotrienes. Okay, leukotrienes are going to play the role. Interleukin 8 is going to play the role, and also complements are going to play the role for the chemoattractants. Right? Next, immediately after that, this chemoattractants is going to include the complement system, and then phagocytosis is going to play to kill that particular inflammatory cell. Right? These are the properties. Next, some of the cytokines that are going to play the major role here in the acute inflammation. Let's see what are those. So we have the pro-inflammation, okay, which increase the inflammation. And other one is the anti-inflammatory, right? They will inhibit or they will stop the inflammation. What are those cytokines, right? Pro-inflammatory, we have interleukin 1, 2, 4, 6 and 8. Okay, 2, 4, 6, 8. Along with that, next for the anti-inflammation, we have interleukin 4, 6 and 10, right? TGF beta and here TGF alpha. These are the pro-inflammatory and the anti-inflammatory. Next, cachexia. What is meant by the cachexia? Completely muscle, bone, everything is going to damaged. That is the cachexia. TNF alpha is going to play the role. Granuloma formation. Granuloma formation, interferon gamma and interleukin 12 is going to play. And next, coming to the fibrosis. Fibrosis formed due to tumor growth factor beta. Eosinophils. Eosinophils is due to interleukin 5 and neutrophils interleukin 8. These are the things that you have to remember for the cytokines. Next, there are also cellular mediators. That is very important. What are the cellular mediators and what are their properties? Right? Here we will see. Cellular mediators. Okay. These cellular mediators. One example is the serotonin. What is the serotonin role here? Serotonin role is to increase the platelets. Okay. And next, histamine. Histamine is very important in this cellular event. because it is coming from the mast cell, basophils also. This histamine will increase the hallmark vascular permeability. It will increase the vasodilation, right? This is the very major role for the acute inflammation in the vascular event. Next, platelet aggravating factor. So this will increase the platelet aggregation. Along with that, it is going to increase the vasoconstriction, and accordingly, it is going to involve in the vasodilation and vascular permeability. This is the platelet growth rate, platelet aggregating factor. And also NO. What is this NO? Nitric oxide. So nitric oxide is going to work with the help of CGMP, right? With the help of the second messenger CGMP, and also arginine. These arginine will also amino acid that is going to include in the NO physiology. And what does the nitric oxide will do? It is the best part of the vasodilation and smooth muscle relaxation. Systematically, it is going to vasodilate and relax the smooth muscle. This is happened with the platelet aggregating. Sorry, this is happened with the nitric oxide. Okay, this is how the cellular mediators is also going to play role. And after this, see this way. Remember this way. Either O2 dependent, O2 independent. Next, moving on to the chronic inflammation, guys. Chronic inflammation. This is the late event, right? Late. So there will be a tissue destruction and also tissue repair. So these are the parts of the chronic inflammation. And what is that one going to involve here? IgG. And what is the cell that is going to involve here? Macrophage or the monocyte. Okay, these are going to play. And ultimately, the chronic inflammation is going to form the granuloma. Okay, ultimately that is going to form the granuloma. What is that granuloma? What is the structure of the granuloma is going to contain? So there will be a 4 properties of the granuloma is going to present here. One is, and most important one, is the epithelioid histocytes. These are the epithelioid histocytes. What are those? These are activated macrophages. Okay, ready to engulf that microorganism. These are epithelioid histocytes. Next, another one is the multinucleated giant cells. Depends on the different type of the cell, it is going to present in the different way. And lymphocytes, immediately, if the macrophages are completed, immediately lymphocytes will going to take place of this ground. Next, the fourth one is the caseous necrosis. Okay, fourth one is the caseous necrosis. All these are going to present in the granuloma structure. Next is some of the examples. The caseating necrosis is seen in the tuberculosis and some of the fungal infections like histoplasmosis. How about non-caseating? So we think that TB and leprosy belongs to the same. So, but leprosy is seen with the non-caseating granuloma. And also most common one, sarcoidosis and cat scratch disease. Okay, Durex granuloma. This Durex granuloma is seen in the patients of malaria. Langerhans, another name for the Langerhans is seen in the tuberculosis. Next, remember this one, Warthin-Finkelday. This is seen in the measles patients. Okay, next, donut shape granuloma is seen in the Q fever, Coxilla. Next, Redstenberg, Hodgkin lymphoma. So these are the some type of the granuloma that is seen in the patient. There will be attacking of the T helper 1 and also T helper 2 cells. What does this T helper 1 cells will do? It is going to include the interferon gamma. So Furtherly, it is going to include the macrophages increasing in the chronic inflammation. Next, T helper 2 cells will include the IL-4 and interleukin 13. So this is also part of including the more and more inflammatory substances is going to involve. So we also seen here for the granuloma, what are those going to include here, guys? Interferon gamma. So that there will be more macrophages will be coming from here, right? Next, coming to the scar. Here you can see this is the hypertrophic scar and this is the keloid scar. Okay, in the hypertrophic, this is most commonly what is the collagen present here? Type 1, which is replaced by the type 3. Replaced by type 3. So most commonly hypertrophic scar is seen with the type 3. Whereas keloid, it is a combination. Okay, it is not going to replace, it is going to contain both type 1 and also type 3. And here you can see this is an organized line, right? Organized line parallel to the scar, right? Here, let's say the scar, it is very parallel to it, parallel to the scar. And next, infrequent, very less, okay, very less. And if the scar is formed here, very less likely to be combinedly, it is going to have the growth. Okay, infrequent growth is seen and no need of the treatment, no need of the treatment for this patient. Next, keloid, it is completely disorganized. Keloid is completely disorganized. It is frequent to cause the extra growth, most commonly seen in the black people. And what is the treatment that we have to give? Steroid injection, okay, with the hyaluronic acid. The drug of the choice for this is the triamcinolone. Injection has to be injected directly into the keloid. Okay, and also remember some of the macrophages as per the system. Where you will see in the liver, you are going to see the Kupffer cells. Okay, liver, you are going to see the Kupffer cells. In the brain, macroglia, and on the skin, we're going to see the Langerhans cells, and in the placenta, and also you are going to see the Hofbauer cells, and in the lungs, dust cells. Kidney is going to have the mesangium, and bones are going to have the osteoclast. These are the types of macrophages forms that is present in the different organ systems. Okay, let's see. Next, moving on to the immune system. This is also one of the most important topic, guys. So in the immune system, what you have to remember. So mast cell is going to produce the histamine, right? It is going to produce the histamine and plays the major role in the it is going to play the major role in the allergic reactions. Eosinophil, same as that, it is also going to produce the histamine and important for the allergic and also IgE related properties. Neutrophil is most commonly seen with the neutrophil is going to most commonly seen in the bacterial infections. This is going to seen in the bacterial infections. Macrophages play the major role in the phagocytosis and also chronic inflammation. Basophils are commonly seen with the leukemias. Okay, leukemias. Next, coming to the T helper cells. As we discussed, there are many types of the immune system cells. Okay, innate immune system and also B cells, T cells, everything will be, there are multiple. Okay, let's see the T helper cells first. T cells, which is going to have the CD4 and CD8. What does this CD4 cell will going to do? These are the main helper cells. CD4 are the main helper cells, whereas CD8 cells are helping in the killing. CD8 is going to help in the killing. Let's see here. The T helper cells are the three types. Okay, TH1 and TH2, TH17. Okay, again see, this is the CD8 classification, which will be contain the TH1, TH2, TH17. Okay, TH1 cells are mostly chronic. Okay, chronic. Here you can see interferon gamma and IL-2. What this going to include? This both going to include the increase the macrophages, and other one IL-2 is also present here. This indirectly includes the CD8 increasing. Okay, and same as here IL-2, it is going to increase the more and more CD8 cells. Okay, which will be helpful in the killing. Next, TH2. In the TH2, we have the IL-2 and also interleukin 2 and also interleukin 13. These 13 is going to increase the mucin. It is going to increase the mucin. And also IL-5, it will increase the eosinophils. Okay, eosinophils. Next, TH17 is going to contain the interleukin 17 and also interleukin 22, interleukin 6 and interleukin 1 is going to present in the T helper 17 cells. All these are important for the acute inflammation. This is going to important for the acute inflammation, right? This is for the chronic, this is for the allergic, this is for the acute type of the inflammation. Next, coming to the B cells. B cells will be mostly T cell independent or the T cell dependent. Okay, let's see. B cell is either T cell dependent or T cell independent. So T cell dependent is only one, T cell independent or only one, that is IgM. Okay, it is only going to independent by the without the T cell. But indirectly T cell dependent are your IgA, IgD, IgE and also IgG. All these are going to be the T cell dependent. And for the B cell, what are the going to be the one which is important for the markers? CD40. CD40 is the marker for the B cells. Okay, this is the thing that you have to remember. Next, moving on to the hypersensitivity reactions and their examples. Next, how can we remember this different types of the hypersensitivity reactions? So remember this way: acid. Okay, what is mean by the acid? First one is allergic related. Second one is related to the cytotoxic. Third one is related to the immune complex. And fourth one is delayed. Fourth one is delayed. What is mean by the allergic type of the hypersensitivity reaction? So it is mediated by the IgE or the eosinophils. So when there is an increased T helper cells 2 activation, T helper 2 cells activation, it is going to include the, what are those T helper cells? Again, come back here, IL-4, IL-5 and also IL-13 and IL-2 is going to increased, right? This is also going to cause the B cells IgE, right? This is the first exposure. Immediately after the second exposure, what happens? There will be again increasing of the histamines from the cells. This granulation from the mast cells, eosinophils, will increase the histamine and cause the further damage to the epithelial cells. What are the examples? For example, atopy, asthma, and eczema, right? Rhinitis, hay fever, all these like food allergy and drug allergy, all these are going to be the type 1 allergy, type 1 IgE related allergic reaction. And also Cassoni test we do for the, particularly for the hydatitis cyst, that is going to be for the IgE related. Next one is the cytotoxic. In the cytotoxics are three types. Okay, cytotoxic are three types. What are those? First one is the phagocytic and receptor related and inflammatory type. Okay, inflammatory type. So what are these? Examples itself will tell. Phagocytic, that means it is damaging within itself cytotoxically. So examples are hemolytic anemia. Hemolytic anemia. Next, receptor related, for example, your myasthenia gravis. Myasthenia gravis. And also Graves' disease. These both are receptor related. And inflammatory type, Goodpasture syndrome. Goodpasture syndrome. Next, third one, type 3 immune complex related. Type 3 immune complex related. These type 3 immune complex related will be what happening here, both the antigen plus antibody, both are going to deposit it. Okay, both are going to deposit it in the tissues where they are going to start the damaging with the help of the complement system. Examples, systemic lupus erythematosus and serum sickness, Heron's clinic purpura, Arthus reaction, rheumatoid arthritis and reactive arthritis, and post-streptococcal glomerulonephritis. And one more thing that you have to remember is the lepra-2 reaction is also seen with the immune complex. Next, delayed type. This delayed type is mostly dependent on the T cells only, right? What are these? Chronic antigen. When there is a chronic antigen, for example, T helper cells, one is going to play role and going to cause the killing. Examples are the Montauk's test. Montauk's test we do for the patients with the TB and multiple sclerosis. Multiple sclerosis, lepra-1 reaction and graft reactions. Okay, type 1 diabetes mellitus. Type 1 diabetes mellitus. These are the some of the examples and types of hypersensitivity reaction. Next, from this picture, what you understand, guys, this is the classic condition of the amyloidosis. This is the classic condition of amyloidosis. The most common amyloidosis is secondary type of the amyloidosis, seen with the amyloid protein. Next, primary type of the amyloidosis is going to have the AL type of the amyloid. Next, transthyretin. Transthyretin, this is seen in the familial type and also seen in the cardiac type of the amyloidosis. Next, we also have the dialysis type where you are going to have the beta-2 microglobin. And in the brain, for the brain, it is Alzheimer's, such as beta amyloid. Okay, beta amyloid, especially 21 chromosome. So seen in the Down syndrome patients also. Type 1 diabetes mellitus, type 2 diabetes mellitus, isolate amyloid. Okay, isolate cells of the pancreas, isolate amyloid. Medullary carcinoma, type of calcitonin. Proyon's disease, it is going to contain the PR amyloid. What is the important one? The best stain for this patient is the Congo red with the polarizing lights. Congo red. Commonly we use is the Lugol's iodine. Lugol's iodine. Right? Most common biopsy spot. Most common biopsy spot for this patient is the abdominal fat. And what is the most common organ that is involved? The common organ is the dialysis. Okay, kidney is the most common organ. The type is most common type is the secondary only, but organ is kidney. Next, what is the most common cause for the death? Death will be cardiac. Most common cause of the death will be cardiac. Okay, this is what we have to know about the amyloidosis. Next, also graft reactions. Okay, graft reaction. Hyperacute is seen in the less than 48 hours. And then acute, most common, this is seen weeks. Okay, next, chronic type. is seen in the months. Okay, months very late. What are the reactions to this one? This is due to type 2. Okay, type 2 hypersensitivity reaction. Immediately, the cytotoxic inflammatory, what we discussed, phagocytic receptor inflammatory, sudden surge immediately within the table also that can be happened. Next, acute within the weeks, which is going to involve the type 2 and type 4. Okay, next, chronic. In the chronic, it is due to type 3 and type 4. Most commonly type 4. Okay, these are the types for the hypersensitivity reaction. And some other important points that you have to remember, like tall like receptor, tall like receptors. In this tall like receptors, tall like receptor 2 is for the TB, tall like receptor 3 is for the RNA virus or the DNA viruses. This is for the gram negative, and tall like receptor 5 is for the flagella. And we also natural killer cells. These natural killer cells are for the innate immunity, right? These are for the innate immunity. And the marker that you have to remember for this one is the CD16 is the best marker for the NK cells. Best marker for the NK cells. And of the NK cells are going to activated with the help of the interleukin 2 and interleukin 15 and interleukin 12. All these three are going to play the major role. And very important, NK cells are going to be seen in the viral infections. Okay, viral infections and tumor cells. Let's continue with the next topic, neoplasia. So we have seen the differences between the hypertrophy, hyperplasia, metaplasia, and the dysplasia, right? Neoplasia. What is meant by the neoplasia? So neoplasia is an abnormal and excessive growth of the cells in the number of the cells and also in the size of the cells and disorganization and other cells. All these type will be combined in the neoplasia. It is always pathological only. So let's see. They are dysplasia. What does mean by the dysplasia? Abnormally development and the differentiation and disorganized. And also next thing that you have to know about the anaplasia. What is mean by the anaplasia? Usually it is going to contains the pleomorphism. Okay, morphism means the structure. It is basically internal or the external. So pleomorphism means, so there will be extreme changes of the size. It can be increased or it can be decreased. And also extremely the shapes will be different. Okay, all these are going to be the different of the pleomorphism. And next, there will be contents of the loss of polarity. Okay, loss of polarity. So important internal organelles that will be not present, like cytoplasm, nuclei, all these are going to be the decreased. Next, nuclei ratio will be increased. Okay, abnormally the nuclear ratio will be also increased in this. So let's see the difference between the two types. One is the benign and other one is the malignant. Okay, so in the benign, you are not going to see the any type of anaplasia. Okay, you are not going to see the anaplasia here, but anaplasia is present in the malignant types. And also growth is ultimately 10 times more. Okay, here growth is only 2 times more. Okay, no local invasion, no local, but there will be a local invasion. Okay, surrounding structures will be affected. No mets, with no metastasis, there will be a metastasis here that is present in the malignant. So what is the hallmark? Is it the malignancy or the metastasis? So the hallmark for the neoplasia is the metastasis, is going to be the hallmark. And metastasis is the three types. One is the lymphoid, and other one is the vascular and direct. Okay, lymphoid examples are mostly like sarcomas, vascular your carcinomas, and direct are like, for example, pseudomyxoma and nearby lymphoid. These are going to be involved the direct invasion. Metastasis type. Actually, what is the most important thing that you have to know about this neoplasia hallmark? There will be increase of the proto-oncogenes. Okay, proto-oncogenes. The name itself telling it is going to increase the oncogenes, which will be including the growth factors and cell cycle regulator. All these are going to increase the growth of the tumor cells. Okay, ultimately they increase the growth of the tumor cells, and there will be another properties like they will going to evade the apoptosis physiological process and also immune response. You are not going to see how to react to these foreign body cells, right? Immune evasion. These are the two things. And for them they also create the angiogenesis. They are also going to increase the angiogenesis with the help of the vegetative epithelial growth factors and other fibroblast growth factors. And also for them, they need the mutations, tumor suppression. Okay, tumor suppression genes are present in our body. So they are going to cause the mutations to this particular tumor suppression genes. And for the food, they have the Warburg effect. Warburg effect. Despite of presence of the oxygen also, they produce the aerobic glycolysis for them to have this particularly the growth for them to increase in the size. Okay, this is seen in the what these are the important properties of the neoplasia. Next, coming to the important points, like first we will see the types of proto-oncogenes. Okay, proto-oncogenes, for example, red gene, this is seen in the men syndrome, men type 2, and also medullary cancer. Okay, medullary thyroid cancer. Next, ALK, this is seen in the adenocarcinoma of lungs. Adenocarcinoma of lungs. Next, KRAS, this is seen in the colon and also pancreas. ABL, seen in the CML. Okay, NRAS. NRAS is seen in the melanoma. MYC gene, in the MYC gene, C for B, CB, Burkitt's lymphoma. L gene for the lung cancer, like small cell lung cancer. And N gene is for the N for N, neuroblastoma. Okay, next cyclin D is present in the mantle disease. Okay, so mantle carcinoma. Next, other important points like tumor EDRF is also going to present in the patients of lung cancer. Okay, these are the some of the proto-oncogenes that you have to remember. Next, coming to the tumor markers. Tumor markers. In the tumor markers, common one, AFE is present in the hepatocellular carcinoma and also yolk sac type of carcinoma. PSA for the prostate, calcitonin for the medullary carcinoma, medullary thyroid, thyroglobin is for the papillary type of the carcinoma, papillary thyroid, and the HCG is for the choriocarcinoma. CEA is for the colon. How about the pancreas? CA19, 9, this is for the pancreas. CA125 is for the ovarian. CA15, this is for the breast. And IGs, immunoglobulins for the multiple myeloma. Immunoglobulins is for the multiple myeloma. And catecholamines, that is for the like your epinephrine, norepinephrine. These catecholamines is for the pheochromocytoma, right? Pheochromocytoma. These are the important tumor markers. Let's see these tumor suppression genes. Okay, tumor suppression genes. What are these tumor suppression genes? Most important and most common one is the P53. Important for the cell regulation also, cell cycle regulation also. The commonly this is present in the chromosome 17p. And if it is mutated, it is going to cause the Lee-Fraumeni syndrome. Lee-Fraumeni syndrome. Many cancers are going to associated with this P53 mutation. And other one is the RB gene. And RB gene is present in the 13 short chromosome Q. And RB gene is going to act as two ways. At the G1 early phase, it is going to be the hypophosphorated, hypophosphorus. Whereas immediately in the G1 late phase, it is going to be the hyperphosphorated. So what happens when this gene is mutated? This phase is not going to happen. So these mutation will cause the three different types of the carcinomas. What are those? Osteoblastoma, and retinoblastoma. You all know. And along with that, there will be an increased chance of the melanoma and lung cancers. Okay, these are present with the RB gene mutation. And NF1, this is seen with the chromosome 17 neurofibromas, and gliomas. NF2 is seen in the chromosome 2, seen with the schwannoma and meningioma. Next, BRCA1 and BRCA2. BRCA1, 17 chromosome again, seen with the breast cancer and also ovarian cancer. BRCA2 with the 13 chromosome, seen in the male breast cancer most commonly and also associated with the prostate cancer. PTEN gene, this is seen with the 10th gene, endometrial cancer. Right, we also know this syndrome as a Cowden syndrome. Right, Cowden syndrome is seen with the PTEN gene. Then WT1 and WT2, this is for the Wilms tumor seen in the chromosome 11. These are very important for us to remember the tumor suppression genes. Next, coming to the carcinogens. What are the carcinogens present in our surroundings? In the carcinogens, the benzidine dyes. This will cause the bladder cancer. Whereas only benzenes, this is going to cause the leukemias. Especially AML is going to cause. Next, arsenic. Arsenic is going to cause the skin cancer. Cadmium is going to cause the prostate cancer. Vinyl chloride is going to cause the angiosarcoma in the lung, angiosarcoma in liver. And aflatoxins is going to cause the hepatocancer. And asbestosis, nickel, this is going to cause the lung cancer. But when they ask asbestosis most specific, if they ask asbestosis most specific, then it is mesothelioma. And most common organism that is involved for the carcinogenesis, EBV. It is going to cause multiple, like it is going to cause the Burkitt's lymphoma, it is going to cause the nasopharyngeal carcinoma, and also Hodgkin lymphoma, and Kaposi sarcoma is due to HHV8 cancer, HHV8 organism. So one of the examples that you have to remember, cystosoma, going to cause the bladder cancer. Right? These are the carcinogens that will be related to the cancer formation. Next, this table is commonly asked radiosensitive versus radioresistant. What are the radiosensitive phases? In the cell cycle, the G2 and the M phase is the most radiosensitive. G1 and S phase is the radioresistant. What are the cells that is most radiosensitive? Lymphocytes. Okay, lymphocytes. Next, radioresistant cells are platelets. Radiosensitive tissue is going to be the bone marrow. Easily bone marrow going to get damaged by the radiosensitivity. And gonads are going to be the organs that is going to damage by the radiosensitivity. And radioresistant brain. You don't see the brain type of the diseases after the radiation. And vagina is the radioresistant epithelium that will be containing. And radiosensitive, if we see the radiosensitive, there will be, if we put the radiation, there is a decrease of the tumors. They are seminoma and they are going to be the Ewing sarcoma. Ewing's sarcoma. Whereas radio-resistant, they will increase the radiation which will cause papillary thyroid cancer. Okay, papillary thyroid cancer. Okay, these are important to remember for the radio sensitivity and the radio resistant. This is for the neoplasm for today. And next, moving on to the genetics and our last topic. In the genetics, we have the different types of Mendelian disorders and non-Mendelian. In the non-Mendelian disorders, here you can see this is one of the paternal and maternal deletion causes. What are those? Let's see. One is Prader-Willi. One is the Prader-Willi and other one is the Angelman. What is mean by the Prader-Willi and Angelman? Prader-Willi, P for Prader-Willi and P for paternal. Okay, paternal deletion, which will cause maternal duplication. Right? The gene that is involved here is the SNRP gene. Angelman is A for Amma and M for maternal. Okay, maternal deletion. Okay, opposite to that, paternal duplication. UBE3A gene is involved. What are the symptoms of this patient? Both patient will be associated with the mental retardation. Along with that, hyperphagia, obesity, and less activeness is present in this patients of Prader-Willi. And in the patients of the Angelman, always smiley faces, mental retardation, and bone diseases that is present in the patients of the Angelman. Let's see the modes of inheritance in the Mendelian disorders. First, here in this pedigree chart here itself, you can understand two things. So autosomal dominants are not going to skip the generation. So every generation is involved in the autosomal dominant. And along with that, you also understand that it is going to show the incomplete penetrance. Okay, incomplete penetrance. Only heterozygous is going to involved here. Next, variability of the symptoms. So person to person in the diseases also, there will be variability of the symptoms. What are the examples? The most common example for this is the Marfan syndrome. Okay, Marfan syndrome. And also achondroplasia, Huntington's disease, Huntington's chorea, and neurofibromatous, ADPKD, myotonic dystrophy, and hereditary spherocytosis. These are the one of the examples for the autosomal dominant. Next one is the autosomal recessive. So there will skip the generations. They will skip the generations. And it is going to present with the carrier. So these carriers is going to, homozygous carrier is going to cause the diseases to the offsprings, commonly seen with the consanguineous marriages, right? Within the family marriages, there is a high risk for these patients. What are the examples? Remember this as a almost all are associated with the inborn errors of the metabolism, and along with that enzyme types. All enzyme types will be your autosomal recessive, and other examples are sickle cell anemia and beta thalassemia, cystic fibrosis and albinism. Again, these all are going to be your inborn errors only. Next, Wilson's disease, right? These are the generations that is going to involve by the autosomal recessive. Next, X-linked recessive. X-linked recessive is always the female. Here, female is going to be the carrier. Female is going to be the carrier, and mostly male patients are affected than the female patients. Okay, mostly male patients are affected than the female patients. And examples that present here is the G6PD, okay, and Lesch-9 syndrome, and Duchenne muscular dystrophy or the Becker muscular dystrophy, and hemophilia A and B. Hemophilia A and B. And one of the other examples are Wiskott-Aldrich syndrome. And remember, Hunter is also X-linked recessive. Next, coming to the last one, X-linked dominant. X-linked dominant is mostly males are going to be the disease carriers. Males are going to be the disease carriers, causing the disease for the children. Okay, and in that, females will be more affected than the males. X-linked recessive, only males are affected. Okay, and whereas here fathers are going to transmit to the fathers are basically going to transmit to the daughters. Okay, this is seen in the X-linked dominant. What are the examples for this? We have Rett syndrome. Remember Rett syndrome and Alport syndrome, and hypophosphatic rickets, hypophosphatic rickets disease, and vitamin D resistance, and also color blindness. All these are going to be seen in the X-linked dominant. Next, mitochondrial. Mitochondrial is going to be only from the mother to children. Is going to carrier to the children equally. Okay, both are involved equally. Examples, Melas syndrome, right? Example, Melas syndromes. All these are going to be the mitochondrial inheritance. Next, coming to the three most important, that is Down syndrome, trisomy 21, and Edward syndrome, E for Edward and E for 18 trisomy, and Patau syndrome, 13 syndrome. Okay, these three are very, very important. What are the features that you have to remember? The features are most common. The genetic disorder associated with the mental retardation is the Down syndrome, and they are going to see the simian crease and this gap between the first and second toes, and associated with the intestinal stenosis, congenital this will be endocardial cushion defects, and prematurely there will be a risk of Alzheimer's in this patient due to the beta amyloid, right? The 21 chromosome beta amyloid, this patient will be contained, and also there will be a risk for this patient with the leukemias, and the most common leukemia in this patients will be the AML, and M7 type is the most common, and most common overall is the ALL that is seen in the Down syndrome patients. And next, coming to the Edward syndrome patients, this is associated with the prominent ospit and mental retardation, low set ears, and also here you can see these rocker bottom feet, specifically seen in this patient, and congenital heart diseases such as VSD will be associated with this patient. Next, Patau syndrome, cleft lip, cleft palate, again microcephaly, mental retardation, and cardiac defects will be seen. Along with that, again rocker bottom foot, but rocker bottom foot is most commonly associated with the patients of Edward syndrome. Okay, next, another two important syndromes that you have to know before we close, that is Turner syndrome, right? Turner syndrome, this is due to monosomy X syndrome. There will be presented with the webbed neck, right? but normal IQ, and there will be also breast decreased development for this patient, and streaky ovaries that is seen in the Turner syndrome, short stature. And when you check this patient for the heart disease, they are going to have the coarctation of aorta. Coarctation of aorta. Next, coming to the Klinefelter. Before that, we see the Noonan syndrome. Okay, Noonan syndrome. This Noonan syndrome is same as a patients with the Turner syndrome only, but they are going to have the mutation with the chromosome 12. Okay, chromosome 12 gene. And what happens in this patient? Usually, they also going to have the Weber neck and short stature, but there will be mental retardation present, and on the heart diseases there will be associated with the pulmonary stenosis. Okay, pulmonary stenosis. Next, you also have the syndrome that is known for the Dijord syndrome, right? Dijord syndrome. And Dijord syndrome name itself, it will tell it is going to involve the third pharyngeal pouch. So third pharyngeal pouch. So there will be cleft lip in this patient also, cleft lip and palate, and abnormal faces, thymic hypoplasia, and also cardiac defects like tetralogy of palate and hypocalcemia due to third pharyngeal pouch is involved, right? And what is the deletion here? 22q deletion is seen here, right? So this is catch, mnemonic is catch for the Dijord syndrome. Next, coming to the Klinefelter syndrome. Klinefelter syndrome, where it is going to present with the 46, 47 XXY, right? This is how it is going to present. And next, what happened? The most commonly they are associated with the hypogonadism. Secondary male sexual characteristics will be decreased, and high risk for this patient with the mitral valve prolapse, and also tall stature and decreased muscular and increased fatty tissue. All the decreased poor bread, beard, and also gynecomastia, all this will be seen in this patient. When there is a risk of the gynecomastia, there is a high risk for this patient with the SLE, and also high risk for this patient with the breast cancer, right? This is seen in the Klinefelter syndrome. Next, trinucleotide repeats. In this, you have to remember CGG is for the Fragile X syndrome. CAG is for the Huntington's chorea, and CTG is the myotonic dystrophy, and GAA is for the Fredrickson's ataxia. So at least these topics you have to revise and read before going to examination, and all these are very important, and the systemic pathology will be included in the medicine. So until then, please revise and practice the MCQs, and happy preparation, guys. See you in the next video. Those who are new to this channel, please do subscribe and share with your friends.